So the questions are at the end. Are we ready for Dr. Kosmac at this point? Is Dr. Kosmac going to present from Germany?
Yes.
So I would like to present Dr. Kosmac, who is an intensivist and cardiologist in Aachen, Germany, and he's going to talk about valved conduits for RVOT augmentation and factors that affecting the choice.
So, hello, can you hear me?
Yes, we hear you.
Yeah.
Yes, can you see the presentation?
Yes.
Yes, we see.
Yeah. Great, great. Thank you. Thank you very much for the invitation. I apologize to be late for the presentation. It's a little bit hectic here at work, but I'm sure I'm happy that this is now working. So I would like to start with the talk on valve conduits for RVOT augmentation and the factors that influence our choices, from durability and hemodynamics to infection risk, reintervention strategies, and the implications for future transcatheter options. So before I start the talk, I want to clarify one thing. I'm not a surgeon, and I'm also not an interventionalist, but perhaps this is an opportunity for me to look at the topic impartially from the outside of both disciplines. So I have no conflicts of interest to declare. The surgical pulmonary valve replacement has been performed for decades with early and late outcomes that are firmly established. Operative mortality is roughly 1%, and freedom from reintervention is approximately 95% at 5 years. The performance of pulmonary valve substitutes is strongly influenced by patient age and prosthesis size. So it's always a fight, surgery versus percutaneous RVOT management. The choice depends mainly on anatomy and long-term strategies. Surgery is required in infants and small children needing conduits less than 16 millimeters of diameter or complex RVOT reconstruction, and in cases of endocarditis or structural conduit failure. The new self-expanding valves now allow catheter treatment even in large or irregular RVOTs, as we heard just now, shifting the pathway towards stage lifetime management. Final decisions rely still on multidisciplinary assessment of imaging, anatomy, hemodynamics, infection risk, and patient goals. So this is a slide I got from a surgeon. This is after intervention, and this is after surgery. But the reason is not that, the surgery would be so superior to intervention. It's just in Germany. It's the DRG system, which reimburses inpatient treatments through case-based payments, which are fully compensated only if the length of stay falls within a predefined reimbursement window. So although transcatheter valve implantation patients can leave the hospital after 1 day, in Germany this is the situation. Surgery remains essential in RVOT management when anatomy does not allow for safe transcatheter valve implantations, such as absent landing zones, very large or distorted RVOTs, or conduit sizes less than 16 millimeters. It's also required when additional cardiac repairs are needed, when conduit failure cannot be treated percutaneously, or in cases of endocarditis. Finally, catheter-related complications must still sometimes be managed surgically. So what is the patient population? The construction of RVPA continuity is typically needed in conotruncal defects with some time of RVOT obstruction, or after Ross-Cono, or Nikaido type procedures for RVOT obstruction. So I took a look at the surgical RVPA placement at our institution in the last 3 years. There were 42 patients with congenital heart disease where a valve conduit was implanted. The most common indication was left ventricular outflow tract obstruction requiring Ross or Ross-Cono, followed closely by truncus primary repair and post-tetralogy repair patients. The other classic conotruncal lesions are also represented. Of note are the 2 endocarditis melody patients that were then treated surgically, and 1 case of transcatheter complication. The age distribution in years is strongly skewed towards infants. There's a second cluster of patients in late childhood and adolescence, and thereafter there are isolated cases that represent a late reintervention. According to age group, the implanted conduits were in infancy Contegra most frequently. Beyond the infancy, there's a mixed distribution. Contegra and Hancock predominate. The other choices: pulmonary homograft, cryopreserved or decellularized, and aortic homograft. We also analyzed the types of implanted valve conduits across diagnostic groups. In our institution, the underlying diagnosis appears to have far less influence on conduit selection than the patient's age at the time of surgery. So what factors we need to consider when choosing the valve conduit? First, the durability is crucial, as conduit longevity varies significantly between homografts, bioprosthetic valves, and synthetic options. Then the hemodynamics, of course, patient-specific factors such as age, expected growth, prior surgeries, and underlying diagnosis. The size availability often limits practical choices, particularly in infants and small children. And finally, for future catheter-based valve and conduit procedures, not all conduits are the same. So on the transcatheter side, you already heard everything in the previous talk. We have in Aachen experience with the Harmony and the Venus P valve. And on the surgical side, as you already have seen, we use the homographs, the Contegra bovine jugular vein conduit, the Hancock porcine vial background conduit, the self-made conduits, EPTFE, and the stented bioprosthetic valves. So first, the homographs. They remain a key option for RVOT reconstruction because they offer excellent hemodynamics, physiologic valve motion, and very low thrombogenicity without the need for anticoagulation. They generally show strong long-term durability, especially in older children and adults, and their regular geometry makes them ideal landing zone for future TPVR. Their main limitations are scarcity, especially of small infant sizes, and degeneration over time, which is faster in younger patients and smaller conduits. Despite this, homographs remain preferred in many centers due to their reliable performance and favorable infection profile compared with several xenografts. The bovine jugular vein, the Contegra conduits, they're widely used. As you've seen also in our institution, they're easy to handle, available in many sizes, and provide good early hemodynamics. They often perform similarly to homographs in the early and midterm, especially when homographs are scarce. The main drawback is the higher late endocarditis risk, and long-term durability can be variable across studies. On the positive side, Contegra conduits usually create a predictable tubular landing zone, which makes them very suitable for the future TPVR. Overall, choosing Contegra is often a balance between availability, anatomy, and institutional experience. The Hancocks, our surgeons say that the Hancocks are coming out of the market. But there are very many patients with implanted Hancocks. They are particularly useful in patients with elevated PA pressures or limited vascular beds, but caution is needed in neonates because of the rigid Dacron housing. What this study from 2010 showed. Overall, it remains a solid option when robustness and predictable performance are required. So the conduits implanted in infancy, this is a study, a pretty old study from Munich, Germany, where they took a look at the different valve conduits implanted. The homografts, the bovine jugular vein conduits, and the Hancock conduits exhibit equal durability after implantation in patients below 1 year of age, independent of their size. Nonetheless, the moderate conduit stenosis or insufficiency develops earlier in patients with a Contegra conduit. Key risk factors for shorter durability were conduit placement in the neonatal period and implantation in a heterotopic position. From this same study, this is the a curve that shows no statistical difference in freedom from conduit exchange for any reason among those grafts. At 5 years, freedom from exchange was 69% for homograft, 59% for Contegra, and 54% for Hancock. A trend favoring homografts, but not significant. By 10 years, the attrition is substantial across all groups. The clinical takeaway would be that in this age group, the choice of conduit should not hinge on exchange-free survival alone. Durability is broadly comparable, and the selection should consider size, availability, hemodynamics, and technical factors. So this slide shows the nationwide German registry analysis over 1,000 patients and over 1,600 pulmonary valves. Replaced, it showed that infective endocarditis risk differs markedly by conduit time. Homografts clearly provide the lowest long-term infective endocarditis risk. The Contegra and its TPVR counterpart Melody, they are associated with a significantly higher hazard of endocarditis and should be selected with caution when infection risk is a key concern. But the expanded polytetrafluoroethylene conduits, they are synthetic hand-sewn valves that use thin, flexible PTFE leaflets, allowing excellent hemodynamics even in very small diameters. An important advantage in neonates and infants. Clinical experience shows high freedom from early reoperation and low early dysfunction, with several pediatric series reporting promising midterm results. Importantly, active development groups in Japan, China, and also Greece continue to refine and innovate these conduit designs, seeking improved leaflet geometry, durability, and valve performance. Planning for future percutaneous valve replacement of the pulmonary valve is a key component of lifetime management in congenital heart disease. Homografts and well-preserved EPTFE conduits currently provide the most reliable platforms for future TPVR, while Contegra and other xenografts remain usable but carry higher infectious and durability risk. The key takeaway from this comparative summary table is that homografts excel in durability and safety. Contegra offers usability but higher endocarditis risk, and ePTFE provides an emerging customizable option, each with clear trade-offs that guide our conduit selection. And so the conduit Oscars, the homograph takes best durability, the Contegra ePTFE win best performance in tiny humans. The stented bioprosthetics grab best future ready role. ePTFE gets best custom design, and Hancock's walks away with most rock solid xenograft. In short, no single superstar, but just a very dysfunctional but talented family. Thank you for your attention.
Thank you very much, Dr. Kosmac. Beautiful presentation covering all the aspects of the material we use for the surgical approach of the pulmonary valve replacement. Now we have time for some questions. I would like to start with first, especially regarding the availability of homographs in Balkan countries. I know that Greece, unfortunately, doesn't have any homograph bank. Turkey is lucky because there is 3 very good homograph banks covering, all the national needs. Especially, when I compare, because in Greece I collaborate with the European Homograph Bank in Brussels. And when I compare the donors' ages, Turkey is really, there is, younger donors, and there is no doubt that there is more pulmonary homographs compared, to those existing in the European homograph banks in Brussels. They have more, aortic homographs, and sometimes, they don't have all the sizes. I would like, this first question is to the audience, what it happens, for example, in Serbia, in Croatia, I don't know, in Slovenia.
Can we start with Serbia?
Yes.
We have a huge problem because we didn't have at all homographs. Unfortunately, now we don't have also the Hancocks, because their Medtronic just told us a year ago that the production is limited and that they're not going to provide us with Hancock, which means that we are now only using Contegras. So I definitely don't know what are we going to do with the patients that are in need for Hancock with the elevated PA pressure, and it's going to be a huge problem in the future.
Yes, because there is no doubt that homograph, is the best choice, especially, even when you compare with the other options.
We cannot import it.
You cannot import.
We cannot import it because we are not in a Eurotransplant. We have not enough. You remember?
Yeah. Because
maybe 15 or 20 years ago, when you came for some patients after the infective endocarditis, we bought due to your connection. But after that,
yes.
Serbia
What I do,
couldn't
in Greece is thanks to my connections that the European Bank continues to provide homographs.
Yes, we needed to give some organs, some donors. And we don't do it, and so we couldn't.
Because I had, a past collaboration when I was in Geneva, and then, out of courtesy of the director of the center, they continue, to provide us homographs. Otherwise, if you don't give hearts, you cannot get this collaboration. Then, with Her Highness Princess Catherine, I started and I brought a professor of histology in order to set up a bank, homograph bank in Serbia. But unfortunately, it's very difficult. Because you do transplant, especially, Croatia, you have a very wonderful program of heart transplantation. What happens in Croatia?
So we have a good heart transplant programs. We are doing primary hearts and then transplant after LVADs. even BIVATs, HeartMate 6 in DAH configuration or whatever. We do have a homograph bank. We started doing this, I think, almost 10 years ago under the Brussels homograph bank. The guys from Brussels helped us a lot to establish the bank. But, you know, it's not enough. We have a lot of our own problems. It's mainly in procuring the hearts, because it's not reimbursed from the Ministry of Health. And then transplant coordinators wouldn't pick up the phone and say, you know, guys, you have a heart somewhere in the area around Zagreb. So we are struggling a lot. We have a couple of these homographs. So I can, pulmonary, for our ROS program, we don't have enough of the pulmonary homographs. I'm suturing the, I don't know, the aortic valve in the graft, in the pulmonary position. This is kind of okay. Of course, the homograft is the best.
You know, you explant a lot of hearts. What do you do with explanted hearts?
Not every heart is suitable for homograft harvesting. We do, and last year we had like 10 heart transplant. It's a major drop in transplant. We don't know why this happened. The year before we had 20, and the number is always around 20. Last year we had a kind of a drop.
Yes, because in Turkey, when you know a heart is not suitable for transplant, they explant and you know they send to the 3 homograph banks. Is you know
we are struggling a lot.
You know, when I compare you know with the situation in Europe, really it's a very successful program in Turkey. And even you know you have very small sizes of aortic homographs, pulmonary homographs. It's wonderful. The only problem, they don't have vascular homographs. You know, the descending aorta, the abdominal aorta, and you know I promote them, you know, to start also the harvesting of this vascular components, anatomical components. But it's a big problem. And then you know the second question, because Dr. Kosmac show the results of the German registry. There is, you know, a high percentage of infection, endocarditis with melody. In the registry, it's 7.5%. I operated 3 cases of infected melodies, and the big problem, you know, despite, you know, very intense antibiotics, you have, you know, the impression sometimes that, you know, there is no more infection. And when I operated, you know, these cases, after surgery, I had, you know, mediastinitis, and the microorganism responsible for mediastinitis was, you know, the microorganism detected during, you know, the endocarditis in the blood cultures. It means, you know, is a big issue, the infection of the melody valve.
Yeah, I do agree. I had 2 cases with a melody endocarditis, and we kind of think about this. This is almost like a malignant endocarditis. This is very severe form of endocarditis, especially if you have a PTFE membrane. Then it's almost like an abscess. It's a terrible endocarditis. As I understand this, the reason for endocarditis is in melody is sometimes the melody is not fully expanded, and then if you have any turbulence, then the percentage of endocarditis will just go sky high.
Yes, and in these 3 cases, you know, the leaflets they were completely destroyed. And then really is very malignant form of endocarditis, because you have the impression that, you know, with antibiotics, you cured the infective process. And then, you know, even during the surgical harvesting, you know, you contaminate the surgical field. And, you know, it was impressive for me, you know, to have this. And the last one I operated 3 months ago in Koch. Do you remember? And it was, you know, the same microorganism. And we spent also a lot of time to cure the mediastinitis. It means, there is some silent microorganisms, and you reactivate them by contaminating the surgical field. Another question. I would like to have a question regarding the echocardiography, magnetic resonance, and so on. There is, still some place for the pulmonary catheterization, or in which cases,
Pulmonary catheterization is not that commonly used anymore, apart from the cases that one needs to do intervention. I mean, catheterization is only, it used to be in the old ages when echo was not that developed, and also the new techniques like MRI and CT scan. Now you can see very well detailed the peripheral pulmonary arteries, the anatomy of the valve. I think MRI is one of the gold standard if one would like to assess the valve leaflets, CT also in order to assess the amount of calcium, how calcified the annulus is. And I think with echo, CT and MRI, one can get all the information that one needs in order to decide what kind of intervention is going to happen.
Even, in cases of intrapulmonary stenosis, do you have, the impression that the cardiac MRI is reliable compared, to the pulmonary catheterization, to pulmonary angiography?
I think MRI is very reliable, I think, with MRI angiography as well.
Yes.
You don't agree?
No, it was a question because I would like, to have also the impact of the. Still, I will tell, I am in favor of the cardiac MRI, but still, I prefer in this cases, to see also the arborization by pulmonary. There is, the only exceptional condition for me to check. Because if you would like to, to go and do, a major surgery, it's better, to know beforehand.
Well, in the only condition you can discuss this would be if you have pulmonary atresia without a VSD, so you have MAPCAS and you want to go and refocalization and create by this main pulmonary arteries. But today you can use IVUS. And IVUS is a very new technique, very good, because it's an ultrasound technique in the vessel. And many centers now use this also to detect peripheral coronary artery disease when we are discussing small vessel coronary artery disease. So I think IVUS will take its place also, removing this indication that we still use when we have pulmonary atresia with an intact ventricular septum and MAPCAS.
Yes, very good. Okay, yes, Dr. Metehan.
My question is that now in current guidelines we have some measurements like 160 for end-diastolic ventricle volume, but for patient group it can be very late because after transcatheter or surgical pulmonary valve replacement, right ventricle is still problematic. Do you think that this measurement will change in future? these numbers will drop to, for example, 140 or 130.
A pulmonary valve replacement, at the very early stage. There is a cutoff value, as you mentioned, is 150 milliliter per square meter regarding, the antiastolic right ventricular volume. But you have also to check the other parameters. For example, if there is a tricuspid insufficiency, if there is a aneurysmal formation due to the previous infundibular patch, this one is very important. If the right ventricular ejection fraction is very important, because sometimes I have poor right ventricular ejection fraction, 40%, below 45%. With no extremely dilated right ventricle. In order to preserve this borderline right ventricular functions, you have to act at earlier stages, I believe. And then when there is, because the right ventricle, as you know, is very arrhythmogenic. Usually, I ask also a Holter monitoring. And if there is some ventricular extrasystoles, arrhythmias, and then I am also very aggressive, especially in these cases.
Can I make a comment on
what? And then, for example, the bulging, this, because when we started, treating this right ventricular outflow tract obstruction in the early 70s, 80s, the tendency was to use large transannular patches. And this one, create a dyskinetic movement. For example, when there is this one, I do a sort of Batista, I remove all this aneurysmal thin myocardial anterior wall of the right ventricle, because it was described from the left ventricle by Batista, a Brazilian surgeon. And he was able, to show by reducing the diastolic diameter of the left ventricle, you increase also in some cases the performance of the left ventricular function. And this one, was taken later by Pedro Del Nido. Probably, you saw. He was doing, the right ventricular Batista, Pedro Del Nido, in some specific cases. Yeah, he published also. And, I am in favor. And in these cases also, don't wait too long.
I was in the period when Philip Bonhoeffer was establishing the Melody valve for the RVOT. And what we saw then, period, was that it's a very heterogeneous type of population. If you remember, Prof, they used to say that for 20 years after a tough repair, okay, you will be able to live without a pulmonary valve. So this is not the case, because as Michael Gajoulis showed also on his work on late tetralogy of alloy repair, it's a different age cutoff when the valve will create by free regurgitation conditions in each patient that will have a bad outcome. So what I believe is that we need to change the strategy of explaining to the patients and the families when they have a tetralogy of alloy that it's not to do the repair, it's to have a very thorough follow-up and find the appropriate time where you need to put the conduit in, either by a Melody valve or surgically. I think this is the most important element, because we pass the message to the families, you have an operation, we call this operation a repair. Complete correction. Yes, you say complete correction, and it's not a complete correction, it's a palliation. No, it's a palliation. And you don't say this to the families, and the families believe that for many years, okay, now the child is growing up and he or she is normal. So I believe we need to change the strategy